Today's webinar on accurate and efficient crown and bridge preparation and impressions. I'm Marty Jablow. I'm America's Dental Technology Coach. I'm here in Woodbridge, New Jersey, where we're having a wonderful summer day. Well, it's come to an end today for me, but we had a wonderful, beautiful weather today, and hope it was the same wherever you folks are. You're going to say, wow, what's this tech guy doing talking materials and impressions and crown and bridge? Well, I'm a wet glove dentist like everybody else, and I got to put my full time in behind the chair, and I get to do these things too. So yes, I get a lot of high-tech stuff, and yes, we still do play with impression material, and it's still my go-to thing rather than scanning, because I'm going to show you a technique I've been using for a long time that takes just minutes and allows me to get very accurate crown and bridge impressions with minimal effort. So again, if you have any questions, you can always get a hold of me, and I forgot to correct the typo on the bottom here. That should be www.dentaltechnologycoach.com. The email address is correct. I had forgotten about that up until just now. So again, if you want to go to the website, it's Dental Technology Coach. And you can get a hold of me at marty@dentaltechnologycoach.com. So any questions, whether it be on what we're discussing tonight or whether it be on something else technology-wise, if you want my opinion on anything, by all means, shoot me an email, and I'll be happy to try and assist you. You can also follow me various places online, on Twitter, Facebook. I have a blog that does a lot of different things, not just technology. It shows a lot of dental research that goes on that most of us would probably miss, and you might like that. And of course, I'm on LinkedIn, so if you want, I'm happy to friend you on Facebook, or make you an acquaintance on LinkedIn. By all means, come on by. And most of all, I would want to thank Premier, because without Premier Dental, we wouldn't be here tonight. They are sponsoring tonight's lecture, and again, wonderful products, and take a look at them, and when you see them at a convention somewhere, thank them for putting on this webinar. So let's get right into it tonight. We've got a few things. Most of us are doing crown and bridge, and it's a big part of our restorative practices. I've been using triple tray or dual arch impressions, goes back, way back. And that's what most people are using these days for, 1 to 2, 3 units, and even more. And I'm going to show you a case that was more than that today. And we're going to talk about how I prepare things, how I impression things, and how I temporize. So, it's just the way I do it, and it's become very efficient and very easy, and hopefully you'll get some tips out of this. Doesn't make my way the right way. That's the important thing to know. You can do things your way. You can modify certain things. There'll be parts of this where I'm going to tell you this is one thing you cannot modify in the impression technique. But for the most part, take what you can out of this, see what works for you, and go with it. It's just something that I've acquired over the years, different things, and hopefully I can bring it all together and give you some tips, make all of our lives easier when we're doing our crown and bridge. All right, so I've been doing this for a couple of decades, right? So I know it works, and I can tell you what the pitfalls are, and I can tell you what the pros are. I try and use a minimal number of burrs, because when I was in dental school, they were telling us to use 1 million burrs to prepare teeth. We used this one to reduce the occlusion. We used this one to reduce the axial surfaces. Then we had to put a finishing burr. You know what? This day and age, I think we don't need to be doing that. In fact, most of the stuff I do was a minimal number of burrs. With a triple tray impression and an alginate pre-op impression that I use for making my temporaries in most cases, I can routinely do a single unit in about 45 minutes, start to finish. Your times may vary. My times vary between each patient, but in a good patient who can open wide, good access, you can do that definitely in under an hour. And minimizing time and materials saves you money. And this days, especially here in the United States, with reduced fee schedule insurances that some of us may be taking, so-called PPOs, everything we can do to save money and time will be a benefit. And that's what I've kind of come to at this point. You can modify these principles any way you want, all right? Nothing here is sacred except for one or two things, which we'll talk about, and I'll make sure you know it. But take what I say, use it, adapt it, change it, and see if it works for you. And if it saves you time and saves you money, hey, that's a great thing. It's really something that I think we would all like to say. So let's get right into it. Part one is preparation. You know, and it's preparing for a whole bunch of things. It's not just prepping the tooth. You want to prepare things in the right manner so that, you know what you're going to do. And, you know, when I was in dental school, basically we had two choices. We had a porcelain fused to metal crown and a full metal or full gold crown. That was kind of it. You know, yes, we had 3/4 crowns and all those other things, but the bread and butter was full coverage, full gold, or PFM. That was it. Well, that's not the case anymore. And in fact, it's making life, I think, a little bit simpler for dentists. The number of PFMs are going down, and the number of ceramic, which are zirconia and Emax crowns, lithium disilicate, those numbers are going up. And that's something that we need to take into account. That, you know what? The days of the PFM are over. So my friend Mike Datola from Glidewell Labs, these are some quotes from an article that was done with him on Dr. Bicuspid. And it's more about the numbers here that he's talking about at Glidewell, which is one of the largest labs in the United States. And they were looking at 2007, 65% were PFMs, and in 2012, it's 20%. Think about that. You know, what we're doing is changing, and it's changing all the time. And in fact, I know in my office, we're doing probably 95% single units or more is definitely zirconia and Emax. And that's over the last few years. Very little am I doing regular PFMs, even doing bridge work with zirconia, you know, and, you know, whether you want to do full zirconia, whether you do porcelain layered on zirconia framework, that's up to you. But, you know, this is what we're looking at, is a total change in what we're doing for crown and bridge. And again, we look at these numbers. You know, zirconia was 13% back in 2007, and now, and these were 2012, it's 56. You know, that's the largest. They're doing 56% of those crowns are coming out as zirconia. Then the rest are coming out as Emax. And from my end, it's made life much, much simpler. You can keep margins supragingival or right at the gingiva. You're not trying to bury that PFM margin. And I took this this graphic off the Glidewell website, and you can kind of get a feeling for why. What happened was I was finding that these are better fit and with less adjustments both in occlusion and contacts when I've gone to these other materials. And you don't have to adapt them. I mean, you look the one on the left, figure one, and that's the way a PFM's supposed to be. But the typical one, as you know, is kind of what they called that mushroom. It kind of sits over there, and the margins stick out. So some people would do a metal collar, which was a way to try and minimize that. But now, when we're getting especially into zirconia, you know, you can even put a feather edge in it. You don't even have to change your preparation. And you can get very, very nice contours, better than I've ever seen on a regular basis from a PFM. Now, I know we can do butt joint PFMs and everything else, but in the standard everyday thing that we do, you know, it's something that you have to consider. And like I said, I've pretty much switched over. But when you're going to select the crown that you want to do, you have to remember the basic tenets of crown and bridge have not changed. Just because the materials have changed, you still have to take into account the occlusal requirements, the forces on the teeth. All right, I wouldn't feel real comfortable putting an Emax crown, let's say, on a short prepped second maxillary molar. You know, you'd probably want to be looking at zirconia or even full gold still. And then we've gone away from some of that metal stuff basically from aesthetic concerns. People prefer non-metal. And once we really started moving ahead in zirconia, this is what's happened. Nobody had to change anything. They can keep doing what they've been doing, and that makes it, you know, easier. We don't have to change, because dentists don't like change, that's for sure. Especially being a tech guy where I'm always changing things in my office, but I know that plenty of dentists don't like to change. They find something that works and they stick with it. So, you know, what we do is based on what we're going to prep, Emax, zirconia, PFM, we have to pick the right burr. And you have to know what that is. What are the requirements for these different materials in terms of prepping the tooth? Well, in dental school, we all did this. We were all taught this. You need at least minimum of 1.5 millimeters. Usually I would try and get 2. You could put in a shoulder, you can put a chamfer. I was a shoulder bevel guy for PFMs, still am. If I'm doing a PFM, I like a shoulder with a bevel. Just my preference. But, you know, the basic tenets of this start with deciding what materials we're going to use. So again, for PFM, these are the minimums. Now, what happens? In most cases, when I talk to my lab, they tell me, if anything, teeth are under-prepped, not over-prepped. For better or worse, I guess that's a good thing, but either way, you should be prepping these teeth properly for the material that you're going to use. Same thing now when we look at lithium disilicate for these Emax crowns. This is in my hands, this is a 1 burr prep. I take a chamfer burr, and I can go around that tooth. I reduce the occlusals that way also, and I can, if you pick the right chamfer burr, okay, and Premier has a whole bunch of those 2-step burrs, you can basically do your depth cuts and kind of go right through it. I like electric handpieces. I think it makes the crown and bridge more efficient and quicker, and something that you might want to think about if you're still using air. But you can now, with 1 burr, pretty much prep the entire, in fact, I do. I prep the entire tooth with 1 burr. Saves time, saves money, and you can still get a very nice prep. You don't have to be switching from burrs to burrs to burrs. When we're looking at zirconia, now zirconia is made, because of the strength of it, is much easier. They're talking about minimum depths of 0.5 to 1 millimeter. Now, I kind of think that you need a little bit more than that. I try and give them a good chamfer or a shoulder. You can, again, with whether it's the Emax or zirconia, you can keep those margins, you know, up. You don't have to start burying everything. I mean, that's why we were taught to put it underneath the gingiva, because we wanted to keep that margin under the gingiva, so we were hiding it. We don't really have to hide these things with zirconia and Emax. So again, you know, 1 burr, you can pretty much go through this, whether you want to put on a chamfer or a shoulder. Very easy. Prep this out, and it's just a simple thing to do with 1 burr. If you keep the burrs to a minimum, whether it's a chamfer, a shoulder, whatever you need to do, you still have to make sure that the tenets of good crown and bridge are followed. Make sure you have enough reduction. Make sure you can see your margins. All right? If you can't see them in that impression, the lab can't see it. You got to remember that. You're the one who has to critique this stuff. Don't just take the impression and send it out without looking. Look at it. Again, I use a single burr for Emax and zirconia. Doesn't take a lot of effort. I try and I'll use a burr once, twice, 3 times in a normal prep, and then it's probably gone. Just to make things simple and let them flow through. So again, 1 or 2 burrs. That should be it. Shouldn't be having to use more than that. Just no real reason to be doing that. Now here's a quick little tip. I use these flex tabs from Kerr. If you want to know how much your occlusal reduction you need, because especially and sometimes with those second molars, it's very difficult to gauge that, and you may not be able to see it. These are little tabs. They're little plastic or rubber tabs that are in different heights, like 1 millimeter, 1.5, 2 millimeters. They come different colors. You put this in between the teeth, the tooth that's being prepped. Have the patient bite into full occlusion, and you see if you can pull it out without any resistance. If you do, you know you have that clearance. If it's getting stuck, you do not have enough clearance. It's very simple. It's a nice little thing to put in the back. You don't use them on every patient, but when you can't see it and you're not sure, it's nice to have something like this to help you out and be able to decide, do I have the clearance even though I may not be able to see it. So, nice little tip. So let's get into prep. Here we're looking at lower left first molar, had a big MOD composite, fractured a cusp. Something you see all the time. She also had a pretty big buccal, as you can see on the radiograph. So again, 1 burr, started doing my reductions. Now I usually, this is just my preference, you can decide for yourselves, I usually do my axial reductions first. I try and use a burr, like in this case, we're going to prep for a full zirconia crown, so I put a chamfer burr in there that's going to be 1.5 millimeters, and I go around. That's it, real simple. So very quickly, I know if I can get that, once I get that, using that burr, I can have 1.5 millimeters reduction. Then I take the same burr and I start doing, my occlusal reductions in the different planes, and we just start the process. Simple crown and bridge. And you get something like this when we're all set and done. And at that point, you're finished. It can be that quick and simple. Average time prepping a tooth in my hands is usually somewhere under 10 minutes. Again, depending on the tooth and the patient and the situation, because not everything is one size fits all. So at that point, after you've prepped the tooth, we've already get into what are we going to do for the impression, all right? Because this is the thing that most of us were taught in dental school, and this is what takes up all the time. What are we using? We're using medicaments, we're using lasers, we're using cord, we're doing all of these things to try and do what? Move the gingiva out of the way. We're trying to displace the gingiva, because this goes back to, a lot of this goes back purely to PFMs and trying to bury the margin. We had to move the gingiva out of the way so that the lab could see the margin, so we could bury it so it was invisible. With that, of course, comes other issues. Those other issues can be a whole bunch of different things, but there's periodontal issues, inflammation, plaque, periodontal disease. All of those things may come into play because we're trying to bury a margin. Well, with these all ceramics, you don't really have to bury the margin. You have to remember that. It makes it easier to attain your crown and bridge. But even in those days when I was doing all PFMs, this technique is what I used. I still use it today for my all ceramics, and it makes crown and bridge literally under 5 minutes, start to finish, excellent results. So we take a dual arch impression tray, quadrant, anterior, whatever tooth you're prepping, and you want to get a good tray. You want to get a tray that's going to lock in that impression material. You prefer a tray that doesn't give. Very, very important that you want trays that are as rigid as possible, because it's going to make your impressions much more accurate. That's really it. It's going to be an accurate impression, because if the tray is bending, the material may give, especially in your traditional impression materials. what you've always been doing, placing your cord, then you're going to syringe into the sulcus, place your impression material, in the tray, have the patient bite down. If anything gives, that material isn't stiff enough to hold the tray in place, and that's where you're going to get problems. So one of the things when using the technique we're going to talk about will be eliminating that. It all starts with a tray. You want a tray that's going to retain the material, wide enough to easily fit in most arches, because again, there's no one size that fits all, as we know with patients. There are occasionally times triple trays won't work. You have to go back to whatever you were doing before that, taking dual arches individually, full arch, whatever you need to do, but it's all going to start with the tray. This takes less time, it uses a lot less material, and patients don't like as much stuff in their mouth, and that's one of the reasons a lot of people are starting to look at digital impressions. Yes, it's cool. I haven't, as of here, 2013 in July, found a really big return on investment for those, especially if you're going to pay click fees and model fees and everything else. You're just trading one thing for another. But the traditional triple tray technique that I'm showing and coming up is takes me less time than in most cases scanning an arch would. This technique is called the H&H technique. Was not developed by me. It was developed by Jeffrey Hoos up in Connecticut, and it literally saves vast amounts of time. And if you want to read more about it, you can see it was published in the Journal of American Dental Association back in 2003, but I've been doing it, I think, even before that. And here, again, another study, Journal of Prosthodontics. If you use a good stiff tray with the proper impression material, it is 12 times more accurate. That's it. The research tells you that these trays and the impression material are accurate, just as good, if not better, than your conventional full arch with a bite registration. So the whole idea of this H&H technique is you take this over impression first after the tooth is prepped. I take many people would consider it the putty, all right, but it's not really putty. You take this impression, very stiff impression, because you don't want anything to move. And we're going to get into that in a second. But then you take it and you wash it with this low viscosity material, and because you put it inside the tray and have the patient bite back down, the hardened material that's in the tray will force this low viscosity material subgingival. It will displace blood, saliva. Now that doesn't mean huge amounts of caked on blood are going to be displaced. You would want to basically rinse it out. But I'm not sitting there placing cord, using medicaments, not taking my lasers, none of that. It forces the material into the sulcus, displacing blood and saliva, and gives you a really good gingival margin. So again, we're not using anything. I'm going to show you these things. You'll see there's blood in some of these pictures. It's immaterial to me. Just a quick spray with my air water syringe before I start, and that is it. So let's walk through a case, and then we will, see what it does, and then, walk through another one. They're always going to be a little bit different. So patient comes in. We're going to start the case. First thing we do, or my assistant does, is take an alginate impression of the teeth. Because in many cases, we have some minor things that may need to be corrected that were broken, but I don't want to have to then make temps from hand. I don't want to use crown formers. I want what was there originally. And if you see here, let's see here, there we go, right there, let's see, right where I'm pointing, okay, there was a missing composite, and we need to correct for that when we're going to be making the temps. So all I do is I take a composite instrument and I just basically festoon it, carve it out, do whatever. This way, I've got good contour, even for a big buccal cusp that might be missing on a molar, you can eye it and just kind of make enough room there to remove the alginate. All my treatment is done under 4.8 loops, so I can see what I'm doing. If you're not doing dentistry with any loops, I suggest that you do, because it just makes it better. For you, it's easier to do. It's better for your patient. If you can see it better, you can do it better. So I'll just festoon these things out and, create the shape and size, or remove the defects that are in the alginate impression. I prep the teeth. Okay, we were doing the 4 maxillary incisors here, and the teeth were prepped, and this is what it looked like. At this point, conventionally, we would be doing cord with medicaments, or there's a whole bunch of different stuff out there that you may be using, or you may even be saying, it's time to pick up a laser. But not in my office. We're not doing this. So we get the tray after the teeth are prepped. We load the tray. Now you can load the tray. You load both sides of the triple tray here. And, my assistant's doing that. And the most important thing, here's where we're getting to that, where we cannot deviate with this technique. You must use a 90 diameter or harder impression material. All right? In many cases, it might be considered a bite registration material. The whole thing here is this material has to be hard enough so that it doesn't expand when you do the next step. So there's a few on the market. Perfect Systems, which is the Merita product. Blue Velvet is one of them. I used Blue Velvet for many, many years with excellent results. Recently, though, I've changed. Saved myself some money. I've moved on to Kettenbach's Futar, which is, if you use Futar, comes in different setting times. I use the Futar regular. It's an occlusal, it's a bite registration, really, material. And it sets in about 1.5 minutes, and we take the first impression with that. Then I reline it with Panasil Extra Light. And that's a very low viscosity material that gets forced into the sulcus and gives me my good impression. So this is the part I was talking about. You cannot deviate from this. Use this material. Use the Merita material. If you're just going to try this with what you have in your office, you are going to have failures. And what will happen is you will have the tooth, you will prep the tooth, you'll take the impression, everything looks really good, the lab makes the crown, and you go to put the crown on, and the crown is too small. What happened was the impression material under the hydrostatic forces expanded, and then what happened was once you took it out of the mouth, it contracted. So it looks good, but it will not work. Very, very important. Use a 90 diameter hardness material, and this will not happen. So these are two good ones, the Merita product, the Blue Velvet, or the Kettenbach Futar. So we prepped the teeth. Here's what it is. I basically blew it dry, rinsed it, and that was it. That's exactly how it looked when we were going to put it in. My assistant's loading the tray, and then sometimes what I will do, you do not have to do this, but sometimes I will then just take the impression material gun and squirt it over the teeth for the first stage impression. We now set the tray in place, have the patient occlude. So we're going to time this out 1.5 minutes. And then what we do is we have the patient open. This is what it looks like. All right? If you look in there, you can see some blood in there, remnants, things like that. We didn't get a lot of bleeding, but, there still was blood in there. So at that point, what I'm going to do is I'm going to rinse out the impression material. I want the blood out of there. I may need to re-rinse and dry the teeth, with a little air and water. Sometimes you will even take this out. You can take it out of the mouth if you choose to. Sometimes I do it, sometimes I don't. Sometimes the patients kind of spit it out, so it's coming out anyway. They're forcing it out. But once you put it back in, you want to have the patient bite in and out a couple of times. The reason is that sometimes this material will get interproximal. And what happens then is as the patient opens, you'll get these little pieces that may break off. And then when they go to bite down, when you're going to take the final wash impression, there's this little piece of material that gets in the way and the patient can't fully occlude. So you need to take that into account. So you rinse out the impression and make sure that the patient can bite freely back in and out of the impression. We then take an extra light wash. In this case, it was the Panasil from Kettenbach, and I then just around the margins. I do not normally fill this all in, although you can do it. I just kind of put the wash just around the margins, and then I have the patient occlude back in. As you can see the green with the purple, and the purple is the wash material that's now being forced from inside the impression into the sulcus and even out of the impression. So we then wait. Again, that's usually about, depending, there's different setting times on this material. Depending on the number of units that I'm doing, we either use the 1 minute or the 2 minute set. It's usually somewhere around 30 to 45 seconds, and the other one's usually about a minute and a half. But I try and make sure with a timer. All right, I don't just guess this. We set the clock and make sure that we take it out in time. So a lot of times I'll give it an extra 30 seconds or so. So the 30 to 45 second set gets a minute, and the minute and a half gets 2, just to make sure everything is set. And then we take out the impression, and that's what it looks like. You should not see huge amounts of the purple, because your preliminary impression set properly will displace that material. And as you can see, most of this is still the green futar, and right around all those margins, you're going to see exactly, how this was forced interproximally. Again, looking at it a little more macro view, zoomed out, that's again what it looks like inside the triple tray. And here's a close-up of that same impression. And of course, this doesn't do it justice, but you can see we've got good marginal adaptation. When subgingival, did exactly what it needed to do. And that whole impression, the whole start to finish, if you took 2 minutes for the initial one and 2 minutes for the second one, and you call it 30 seconds to a minute in between, this is a 5-minute impression, start to finish. So I go back to, we're done with the impression, I go back now to my alginate, and I've taken my, my shade, and then I select my appropriate temporary crown and bridge material. Again, single units, almost really doesn't matter what we use. When we start getting into crown and bridge in long spans, some stuff is more brittle than others, so you might want to select something that's going to be a little stronger than a single unit. My current ones that I use everything from Pentron's Tempspan. I use Tough Temp. What else do I use? Trying to think what else is in there. Kettenbach's Visceral, and trying to think. There's one other one. Can't remember it right now. That we're using on a regular basis. But they all have different properties. Oh, using the new Voco material, Structure 3, which is really nice because to polish it, all you do is take a little alcohol on a gauze and it shines right up. So, there's a whole bunch of them. We use a whole bunch of different ones in my office based on what the needs of the patient are. We then seat the alginate into the patient's mouth. And this is what we get. We get the temps in, take the temps out, tease them out. We get some good temporary cement, like the Next Temp from Premier. This is a stiffer temporary cement that, let me tell you, if you've got good resistance and retention and you use this cement, it's not coming off. I'm having more trouble taking off the temps than sometimes I'd like, but I feel really confident, especially if I've got a short prep or something, that this temporary cement will definitely do the job for me. And here's the way the patient walked out. All right, so in this case, these were 4 CapTech crowns that we were doing in this situation. And these are the temps, still waiting for the case to get back. But this is what we're looking at. Very quick, very simple. I believe this whole thing, start to finish, was probably about an hour and a half. It was definitely under 2 hours, if I remember correctly, to do all those 4 teeth, prep them, temp them, impression them, and, talk to the patient in between. So that's one case, but that's a little bit more involved. But the standard crown and bridge stuff, is really just as simple. This was that case that we were looked at earlier where I prepped the tooth. I forgot to take the pre-op of the alginate with the defect in it, but we've already modified the defect here for that broken cusp. And this is a very good picture. Again, everyone's going to be different, but this was the stage 1 impression. All right, using the 90 diameter or harder material. Again, this was Futar. And you see, I didn't capture everything. That's not necessarily the need of this. This is a 2-step impression technique, and you just want to make sure that you've got enough material around that tooth so that you're going to be able to force the material into the patient, into the sulcus. And this is what it looked like when we were all said and done. Again, you can see that the material in the middle, is definitely been displaced. You've got a nice margin with your purple material. And if you look to the distal there, to that second molar, you can see how it was even forced subgingival on that molar. And, those are the things that really make this a simple technique. You do this and, it eliminates all that time, especially if you miss the impression. We all know and we all miss impressions. What happens? I got to go back. I'm going to place more cord. I got to retake the impression. When you start retaking impressions at $25 and $30 an impression, it gets expensive real quick. With this, I can't tell you that I haven't taken, other impressions, but, it's really, really a minimum that I have to worry about that, because I'm using the physics of that hydraulic pressure to push that material subgingivally, not trying to use the gun to place the material into the sulcus and hope the other material then compresses it in. So again, it can save you a whole lot of time, and my standard crown and bridge are 1 shot, 5 minutes, start to finish. It's just a really, really easy thing to do, and it's what we do every day in my office. So then we went back to the alginate, and we placed the temporary material, and we have the patient bite back down in. If we're using, you can use a triple tray. I do know people, I use alginate because it's cheap, but I do know people who will take a PVS impression, even in a triple tray, and save that while the patient is out waiting for the crown to be made. When they're doing that, the whole idea of that technique is that should that crown be lost, broken, or anything else, they can easily remake the temp. So different technique, same idea, taking the impression of what's there and using it so that when we use these materials, it's minimal adjusting. Again, it's a couple of minutes for this stuff to set, and in many cases, once I trim it up, we're talking about, again, 4 or 5 minutes tops from start to finish to fabricate and seat the temporary crown. So again, I'm just carving this up using whatever you feel comfortable with. I use some sandpaper discs, carve it up, and then I polish it up with composite, points or flat instruments, whatever you normally would use, and we'll polish that up if necessary. A lot of times I don't need to. If I use something like the Structure 3 from Voco, I can do that too. Just wipe it. And then here you go. You check it. You want to make sure you've got good fit, contacts, margin. Everything should be good. I'll do a little carving into it if I need to. Maybe not on a molar. Patient really doesn't care too much. We're not going crazy about the aesthetics in that, and this is what we get. We then, of course, seat the crown. Usually what I'll do is I will place it into the mouth. I take a cotton roll, have the patient bite down on it, set the timer again. I'm big on setting the timer because if I don't set the timer, what usually happens is I get the whole, I get impatient. That's the only way to describe it. My attention span is too short. And I set the timer. I then go in. I remove the excess cement, and the patient's done. Now, one of the things that we talk about a lot of times in Crown and Bridge, especially when taking triple tray impressions, is patients bite in different ways. All right, that's something that we have to look at, and the whole idea is, well, where's their bite? And we have patients that don't even know where their bite is because it's always a moving target. So one of the things that we do in those patients where we're not sure that we can get them back into the good centric occlusion position is before we do any impressions, what I'll do is I'll take these little check bites, take a little bite registration material, and I place it on the contralateral side and have the patient bite in. No trays, no nothing. They just close. This is their proper CO. When we do that, now what we've got is, a good guide. It's exactly what I'm talking about. It's a guide for the patient. So when you put that triple tray on the other side, and you know how when you ask a patient to bite, they're always trying to help you, and they move the jaw in that direction? Well, this is going to be the guide, so you will absolutely know if that's something that you want, if they're in the right place. That's really it. So you do that, and, here you can see I prepped the tooth on the lower left. You see the blood over there, and that's what we're doing. And we use that as a guide to make sure they are in the proper place. Again, don't use it all the time, but it's a nice little tip when you've got that patient who just doesn't want to keep biting into the same place, or they're in that big group function and they slide forward and back and all over, or they just trying to help you but they can't. And that's really where it's at. So just another little tip or trick that sometimes can bail you out here when you've got that kind of patient, and you need to find a way to make sure they're biting in the right place.